Imagine it's 2036. A friend shows you a photo from 2021. Everyone looks a little different. Not because humanity suddenly discovered kale, but because sometime in the mid-2000s, a class of medicines quietly changed what being overweight even means. And here's the uncomfortable part. Even if the hype dies tomorrow, this era probably won't. Not because of celebrities, not because of TikTok, but because we accidentally built something rarer than a miracle weight loss shot, a platform technology that plugs into the deepest parts of human biology. So today, let's talk about why the Ozempic era won't die, what these drugs actually do, what they don't do, and what the next decade will look like when your appetite becomes negotiable. And as always, this is education, not medical advice. If you're considering any medication, talk to a real clinician. First, zoom out. In 2022, about 2.5 billion adults worldwide were overweight, and roughly 890 million were living with obesity. That's not a niche problem, that's the default human condition on a planet where calories are cheap and bodies are old. And according to a major global forecast, by 2050, almost 2/3 of adults could have overweight or obesity if current trends continue. In the US, adult obesity sits around 40%. That's not a few people who lack willpower. That's a full-blown environmental mismatch. And then, suddenly, a new thing happened. Normal people started using powerful appetite drugs at population scale. In 2024, about 12% of US adults reported they had tried GLP-1 drugs. By late 2025, another poll suggested about 12% said they were currently taking a GLP-1, an enormous number for a prescription class that until recently was mostly diabetes meds. That adoption rate alone is enough to bend markets, clinics, and culture. But adoption isn't what makes this era sticky. The real reason is that these drugs attack obesity at its most stubborn layer, the machinery that generates hunger. To understand that, we need to talk about the appetite algorithm. Your body does not experience hunger as a simple meter that fills up when you need energy. It's more like a committee. Signals from your gut, your fat tissue, your pancreas, your brainstem, and your reward system constantly argue about what to do next. Eat now, wait, stop, keep going, go find sugar. And this committee evolved in a world where famine was normal. That's why hyperpalatable foods, high in sugar, fat, and salt, feel like loot drops for your brain. Not because you're weak, because your nervous system is doing exactly what it was designed to do. Modern food makes this worse. In a tightly controlled clinical experiment, people fed an ultra-processed diet ate hundreds of extra calories per day compared to a minimally processed diet, even when meals were matched for things like sugar, fat, fiber, and macronutrients. Convenience and texture can bypass "I'm full" signals. So yes, behavior matters. But pretending biology and environment don't exist is like blaming a thermostat for the weather. Now, enter GLP-1. GLP-1 is a hormone your gut releases after you eat. It helps your pancreas manage blood sugar, slow stomach emptying, and, most importantly for weight, talks to brain circuits that shape satiety and food motivation. But natural GLP-1 is basically a disappearing message. It vanishes in about 1 to 2 minutes because enzymes like DPP-4 chew it up. So scientists did the obvious thing. They hacked the message. GLP-1 receptor agonists are drugs that mimic GLP-1, but stick around far longer, often long enough for weekly dosing. That turns your gut's gentle, maybe chill whisper into a steady background signal that says, "We're good. You can stop now." And for many people, that changes the subjective experience of life. People often describe obesity as having food noise, a constant, intrusive pull toward eating, When that noise drops, it's not just weight loss, it's cognitive bandwidth returning. So how powerful is the signal? In the Step 1 trial, people given weekly semaglutide 2.4 milligrams plus lifestyle changes lost about 14.9% of their body weight at 68 weeks versus 2.4% with placebo. Tirzepatide, a dual GIP/GLP-1 drug, pushed this further. In SURMOUNT-1, higher doses produced average weight losses in the low 20% range at 72 weeks. But here's the catch. The lever keeps working only while you're holding it. In SURMOUNT-4, participants lost about 20.9% during a 36-week lead-in. When some were switched to placebo, they regained weight. When others continued therapy, they lost more and maintained far more of the initial drop. And this rebound is not unique. In the Step 1 extension, people who stopped semaglutide regained about 2/3 of the weight they'd lost within a year. So if you're thinking, this sounds like something you might need long-term, congratulations. You're already seeing why the era won't die. Because once a condition is treatable, society reorganizes around that fact, but we're not done. Weight loss is only the entry point. The real tectonic shift is that GLP-1 drugs keep collecting new side quests. In the SELECT trial, more than 17,000 people with overweight or obesity, established cardiovascular disease, and no diabetes, weekly semaglutide 2.4 milligrams reduced major cardiovascular events by about 20%, 6.5% versus 8.0%. Hazard ratio 0.80. That result was so strong that regulators expanded indications. In 2024, the FDA approved Wegovy to reduce the risk of serious heart problems in this specific population. Meanwhile, tirzepatide collected another indication. In late 2024, the FDA approved Zepbound for moderate to severe obstructive sleep apnea in adults with obesity, and long-term metabolism prevention signals are emerging. In a 176-week trial analysis in people with obesity and pre-diabetes, tirzepatide sharply lowered progression to type 2 diabetes versus placebo, 1.3% versus 13.3% at 176 weeks. Some of these benefits are just the physics of weight loss, but others show up faster than you'd expect, hinting that changing gut-brain signaling may shift whole-body risk systems, not only the scale. Which brings us to the part nobody saw coming. Cravings. There's now randomized trial evidence that semaglutide can reduce alcohol craving and reduce alcohol consumed in a lab self-administration setting in adults with alcohol use disorder. Small study, short duration, but real, and large observational analyses have linked GLP-1 or dual incretin prescriptions to lower rates of severe outcomes like opioid overdose and alcohol intoxication in people with substance use disorders. That's not proof, but it's a serious signal. This doesn't mean GLP-1s are anti-addiction drugs, but it does show something bigger. These molecules are not just obesity drugs. They are behavior-modulating hormones. Now, if this all sounds too good, it's because it comes with 3 big prices. Price number 1 is literal money. In the US, list prices have hovered around the $1,000 per month range, with complex discount programs and uneven insurance coverage. But even that is changing. Reuters reported Novo Nordisk plans to cut US list prices for Wegovy and related products by up to 50% starting in 2027, suggesting competition and policy pressure are finally bending the sticker price. Price number 2 is side effects. The most common problems are gastrointestinal, nausea, vomiting, diarrhea, constipation, especially during dose escalation. Serious events like acute pancreatitis are rare, but real enough to sit in prescribing information and safety monitoring. Labels also include class warnings and contraindications related to thyroid C-cell tumours seen in rodents and specific thyroid cancer risk syndromes, and safety narratives can also update in both directions. In early 2026, the FDA requested removal of a suicidal ideation warning from GLP-1RA labeling after it did not identify an increased risk. Price number 3 is muscle. When you lose weight rapidly, you don't only lose fat, you lose lean mass too. DXA sub-study findings in semaglutide trials show major fat loss, but also lean mass decreases. Similar body composition work exists for tirzepatide. This matters because muscle is not just for looking athletic. It's your metabolic buffer, your mobility reserve, your don't break a hip at 70 insurance. So the future of GLP-1 medicine likely won't just be more weight loss. It will be better weight loss, preserve muscle, reduce visceral fat, and maintain results with fewer side effects. And that brings us to the next reason the era won't die. The tech is improving fast. We're moving from weekly injections to new delivery devices, and, most importantly, pills. Orforglipron is an oral small molecule GLP-1 receptor agonist. In a 72-week trial in adults with obesity, it produced significantly greater weight loss than placebo. And as of early 2026, companies were reporting head-to-head diabetes data that shows meaningful weight loss while also reminding everyone of the eternal trade-off. Tolerability still sets the ceiling. Oral drugs matter because they scale globally. Easier distribution, lower barrier to starting, and potentially to long-term use. If injections made this a trend, pills could make it infrastructure, which is why even global public health institutions are adapting. In late 2025, the WHO issued guidance recognizing obesity as a chronic disease and supporting long-term GLP-1 therapies for obesity in adults as part of comprehensive care, while emphasizing access and equity risks. So the Ozempic era won't die because the need is gigantic. The biological lever is real. The benefits are expanding beyond weight. The delivery is getting easier. The cost curve is starting to bend. And institutions are rewriting standard care around long-term treatment. But there is one thing that could still kill this era. Not a single scary headline. Not a backlash tweet. Not even cultural fatigue with weight loss discourse. What could derail it is a mismatch. If we treat these drugs like beauty products instead of chronic disease tools, we'll get chronic disease outcomes. Because obesity doesn't happen in a vacuum. Access is unequal. Food environments are unequal. Healthcare is unequal. And if only the privileged can afford appetite control, the health gap widens, a concern explicitly raised in global guidance discussions. And if people chase the fastest possible weight loss without nutrition and resistance training, we'll trade one problem for another: frailty, weakness, and rebound. There's also a darker shadow: unregulated copies. When a drug becomes a cultural phenomenon, counterfeits and risky workarounds follow. In early 2026, the FDA warned consumers about illegally sold, unapproved GLP-1 products marketed as research versions but used as medicines, of unknown quality and potentially harmful. So here's the real conclusion. The Ozempic era won't die because it isn't one era. It's the beginning of a new relationship between your brain and your metabolism. In the old world, hunger was a command. In the new world, for millions of people, hunger can become input, one signal among many. That doesn't magically create a healthy society, but it can reduce disease risk in high-risk groups. It can make long-term behavior change less punishing for some people. And it can give people room to build habits that used to be crushed by biology and environment. If we do this well, ethically, equitably, and with respect for the complexity of bodies, future humans might look back at our decade the way we look back at the introduction of antibiotics, a moment when something that used to feel inevitable stopped being inevitable. Just maybe. with fewer side effects and better snacks.